The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to today's program, Rare Bleeding Disorders During Pregnancy. My name is Dr. Annabelle Frank, and I am a Hematology Oncology Fellow at the University of California, San Francisco, and I will be moderating today's program. A few words about the Foundation. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the Foundation has focused on realizing its vision through these objectives, as you can see displayed here. Some housekeeping. To ensure the best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a Q&A session with Dr. Abel and myself at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we'll address them during the Q&A at the end. Now, I would like to introduce Dr. David Abel, who is an assistant professor with the Department of Obstetrics and Gynecology in the Division of Perinatology at the Oregon Health and Science University. We are so grateful for this opportunity to share our knowledge with you today, and thank you to Dr. Abel for being here. Before we begin, the next few slides detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by Gladwell CME and the Foundation for Women and Girls with Blood Disorders. We have no relevant financial relationships to disclose, and the activity is being provided independent of industry support. CME will be provided to physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME/CE credits for the program after its conclusion. Attendees of today's program will receive an email after the program's conclusion with evaluation and details. Please send any CME questions to Brian at the email provided. So before we begin, we would like to do a quick poll to see how many people are joining us today. Make sure everybody knows how to use the poll. So we're going to see who's joining us with others. Please take a moment to answer the poll questions on your screen. So it looks like a lot of people have answered, 86%, that's great. Give people a couple more seconds. And most people are joining on their own. A few groups. Okay, I think we can go ahead and close the poll. Thank you so much for your responses. And I will now turn the call over to Dr. Abel. Thank you so much, Dr. Abel. We're delighted for you to be here.
Thank you, Dr. Frank, for that introduction, and a big thanks to the Foundation for Women and Girls with Blood Disorders for the invitation to speak with you all today. I would like to extend my thanks to Dr. Andy James, who was the founder of this great organization and my mentor when I was a fellow at Duke. She is definitely the main reason why I became so interested in obstetric hematology. So these are our learning objectives for today. Our objectives for this talk are as follows: to appreciate the physiologic changes during pregnancy and how they may impact the management of rare bleeding disorders during pregnancy. 2, to understand the possible complications of rare blood disorders during pregnancy. And finally, to identify possible management strategies for pregnant persons with rare bleeding disorders. Next slide, please. So here are some pre-test questions that I'm going to read. Which of the following decreases during pregnancy? Factor 7, 10, 11, or 12? And next question. The association between coagulation factor activity level and clinical bleeding severity is weakest for which of the following? Factor 7, 10, 11, or 12? And our last question, which of the following factor deficiencies has consistently been shown to be associated with miscarriage? Factor 7, 10, 11, or 12? And okay, I think we can go to the next slide. Great. So as far as an outline for the talk, we will primarily focus on factor deficiencies, and specifically for factors 2, 5, 7, 10, 11, and 13. We will also address fibrinogen disorders and finish up by briefly discussing inherited platelet disorders. Next slide, please. Let's start off with some general statements regarding rare bleeding disorders during pregnancy. As we would expect, factor 8 and 9 deficiencies, hemophilia A and B respectively, and von Willebrand disease make up most of the inherited bleeding disorders, with the remainder the rarer bleeding disorders that we will discuss today. As these are rare, the prevalence of these conditions, as you would expect, is low, ranging from 1 in 500,000 individuals to 1 in 2 million. Most of these are inherited in an autosomal recessive fashion. So as you might expect, carriers, that is heterozygotes, are less affected and often asymptomatic with about half of the normal coagulation levels for the specific condition. There is an exception to this, as we will later see in the talk. Next slide, please. Please keep in mind that there is a paucity of data with regards to most of these conditions, and data is primarily based on case reports and case series and expert opinion, essentially level 3 and 4 evidence, as prospective studies really aren't feasible. In many cases, neuraxial anesthesia during labor is avoided, and for the fetus that is suspected of being homozygous for a particular condition, usually operative delivery and invasive procedures in the intrapartum period are avoided, mainly to decrease the risk of intracranial hemorrhage. With severe deficiencies of certain coagulation factors, postpartum thromboprophylaxis and nonsteroidal analgesics are usually avoided. Finally, specific recombinant or virally inactivated plasma-derived factor concentrates are preferred over fresh frozen plasma or cryoprecipitate, although both are utilized, as we will see. Next slide, please. This slide illustrates the physiologic changes during pregnancy as they affect parameters involved in coagulation. Note that factors 2, 5, and 9 remain relatively unchanged. These changes that you see here contribute to the hypercoagulable state of pregnancy, in which there is a 4 to 5-fold increased risk of thromboembolism. This hypercoagulable state is essentially a defense mechanism, if you will, against the bleeding that may occur during early pregnancy and definitely during delivery. Next slide, please. During our discussion, you will often hear me talk about the risks of both primary and secondary postpartum hemorrhage associated with many of these rare bleeding disorders. Secondary postpartum hemorrhage is also referred to delayed postpartum hemorrhage. This slide demonstrates how 3 different organizations differ with respect to the definitions of postpartum hemorrhage. I don't think it is really that important to understand these differences, but rather to illustrate to you that there is not a consensus on these definitions. Note that the definition of secondary or delayed postpartum hemorrhage is bleeding that occurs greater than 24 hours after delivery up to either 6 or 12 weeks postpartum. Next slide, please. Okay, so let's get started and spend some time discussing these rare factor deficiencies. Next slide. So we'll start with factor 2, or prothrombin deficiency, which has a prevalence of about 1 in 2 million. Like most of the factor deficiencies, it is inherited in an autosomal recessive fashion. Complications that have been reported here include miscarriage, both antepartum and postpartum hemorrhage, primary and secondary, and there is a reported case of a spontaneous maternal subarachnoid hemorrhage. Next slide. Purified single factor concentrate is not available. So instead, prothrombin complex concentrates are often used, although fresh frozen plasma can also be used. Keep in mind that prothrombin concentrates may be associated with thrombosis. Cryoprecipitate lacks prothrombin and should not be used. If the patient has been receiving prophylactic prothrombin concentrates prior to pregnancy, these are usually continued throughout pregnancy, with the goal of a factor 2 activity level of at least 0.2, and some say up to 0.4. If factor 2 activity is less than 0.2, and there are concerns for bleeding, or there is labor, and prior to a cesarean section, prothrombin concentrates at a dose of about 20 to 40 IUs per kilogram may be considered to maintain an adequate factor 2 activity. These prothrombin complex concentrates may also need to be continued postpartum. TXA, tranexamic acid, is something you're going to hear me talk about throughout the talk, and as an antifibrinolytic, as you will see, it can be helpful for both prophylaxis and treatment in these rare conditions. With regards to when TXA prophylaxis is initiated and how long it is continued postpartum, there really is no consensus. So management, as it is in most cases with these rare bleeding disorders, is individualized. Next slide, please. Let's move on to factor 5 deficiency with a prevalence of 1 in 1 million. Now, factor 5 activity levels do not necessarily correlate with the severity of clinical bleeding. Virally inactivated fresh frozen plasma, sometimes referred to as SD fresh frozen plasma or solvent detergent FFP, is the preferred source of factor 5, as no commercial factor 5 concentrate is available. Platelets do provide an alternative option, as they contain about 20% of the normal circulating supply of factor 5. Postpartum hemorrhage is a reported complication, and there was a case report I saw of bleeding that persisted for 2 months postpartum, where FFP prophylaxis was not used. Now, in terms of management during labor, the actual risk of bleeding and the best way to reduce the risk of hemorrhage are all unknown. If the patient is asymptomatic, a proposed factor 5 level to maintain is 0.12. Next slide, please. In addition to SD, FFP, as I mentioned, TXA may be used for minor bleeding. I have put suggested FFP dosing for labor or prior to a C-section here if there is significant bleeding and or if a factor 5 level is less than 0.2. Again, please keep in mind that if you do reading on this, you will see difference of opinions with regards to the dosing and even duration. FFP can be continued every 12 hours to maintain a factor 5 activity greater than 0.2 for at least 3 days. Also, platelet transfusions can be considered. Next slide, please. So moving on to factor 7 deficiency, which is actually the most common autosomal recessive coagulation disorder with a prevalence of 1 in 500,000. Now, this entity is clinically heterogeneous, ranging from an asymptomatic patient, which is noted in about 30% of those with the condition, all the way to lethal. Similar to factor 5 deficiency, clinical bleeding severity does not necessarily correlate with factor 7 activity level. A distinguishing feature in this condition is that a severe bleeding type may be seen in 2% of heterozygotes. Now, this is not typical, as most heterozygotes of the other rare bleeding disorders are usually not symptomatic. And it is the opinion of many that a history of bleeding may be more predictive of bleeding than the actual factor 7 level. Next slide, please. Now, having said that, severe bleeding is more likely with a factor 7 activity of less than 1% or 0.01. Pregnancy usually does not require special precautions, and an uncomplicated delivery is possible without prophylaxis. Both antepartum and postpartum hemorrhage, as well as pregnancy loss, have been reported. The clinical history here seems to be important. If there is no history of bleeding, the risk of postpartum hemorrhage, as far as we know, does not appear to be increased. Next slide. Several therapeutic options are available to treat and prevent bleeding episodes in patients with severe bleeding symptoms, including fresh frozen plasma, prothrombin concentrates, plasma-derived factor 7, and recombinant factor 7. Where available, recombinant factor 7A is the preferred option due to the low likelihood of viral contamination and a low infusion volume. Now, I do want to add that I realize that many of the strategies for prophylaxis and treatment that we are talking about are extremely expensive. And often you have to go through some hoops to get these to be approved. So it's not that easy when I just say, oh yeah, just give some factor 7A and that. It's certainly more involved than that. And we struggle here with that. Recombinant factor 7 is commonly administered at a dose of 15 to 30 micrograms per kilogram. After a cesarean section, the recombinant factor 7 could be continued for several days if there is a history of bleeding and a third trimester factor 7 level was less than 2%. Again, TXA can also be used alone or in conjunction with recombinant factor. Now, even without any bleeding, many will use TXA prophylactically. There is no consensus as to use it only for bleeding, the TXA that is, or how long to continue it in the postpartum period. Next slide. Now, there's really not a whole lot out there about factor 10 deficiency during pregnancy. There were reports of postpartum hemorrhage even in those who received prophylaxis, and a report of life-threatening hemorrhage. High purity plasma-derived factor 10 concentrate was approved in the United States in 2015, and there is minimal experience with this during pregnancy. Fresh frozen plasma and prothrombin complex concentrates are often used for prophylaxis. The most seriously affected tend to be the patients with a severe deficiency of less than 1%. If the factor 10 level is greater than 10 to 20%, and there is no history of significant bleeding, conservative management may be used. Next slide, please. Next is factor 11 deficiency, which is inherited in an autosomal recessive fashion. It has a prevalence of about 1 in 1 million, However, it is significantly more common in patients of Ashkenazi Jewish ancestry, with an 8% heterozygosity rate. Homozygous patients usually have a factor 11 level less than 0.15 to 0.2. Now, even among individuals who have the same factor level, clinical phenotypes may vary. In most cases, even in those with very low factor 11 levels, spontaneous bleeding is rare. A residual bleeding risk does exist after surgery or trauma. Next slide, please. Factor 11 levels appear to be weakly correlated with the clinical phenotype. Both primary and secondary postpartum hemorrhage has been reported, and TXA prophylaxis has been used with some success. In patients with a bleeding phenotype, some recommend an extended use of TXA postpartum. And again, this is where management is individualized, because I can't tell you, well, for how long postpartum? And I think it depends on the clinical situation, how much was there bleeding during delivery, bleeding history, etc. Virally inactivated, purified factor 11 concentrates are available in Europe, but not in the United States. It also appears that the clinical history may actually be more important than the factor 11 activity level itself in terms of predicting the postpartum hemorrhage risk. And again, as I mentioned, TXA can be used, and for prophylaxis, the optimal agent, dose, and duration all remain unclear. Next slide, please. So let's finish our discussion on factor deficiencies with factor 13. It has a prevalence of about 1 in 2 million, and reports consistently seem to demonstrate an increased risk of miscarriage. The incidence of postpartum hemorrhage in these patients is really not known. Plasma-derived factor 13 and recombinant factor 13 are commercially available in many countries. However, experience with recombinant factor 13 during pregnancy is extremely limited. Still, factor 13 concentrate, as well as fresh frozen plasma and cryoprecipitate, have all been used as replacement therapies that have resulted in successful pregnancies. Next slide, please. It has been suggested that the risk of pregnancy may be reduced with the use of factor 13 concentrate. There is no data with regards to neuraxial anesthesia in the intrapartum period. It is felt by some that a factor 13 level of greater than 10 to 20% is necessary to achieve successful pregnancy, and replacement therapy should be used if necessary to maintain these levels. Okay, well, we have completed the discussion on factor deficiencies, and perhaps you are feeling a bit unsatisfied, kind of expecting more of like, hey, tell me what to do here. And unfortunately, there are some guidelines and some suggestions. And one of the resources that I put in the references that's really good is from the Royal College of Obstetricians and Gynecologists from 2017, which is their Green Top Guidelines number 71. And you will have access to my email. And if anyone is interested, I am happy if you email me to send you that. as well as I can send you many other articles on all of the topics we are discussing today. But this green top guideline is kind of nice because it does, in kind of a concise way, make some recommendations. Granted, not the best evidence, and grades of recommendations are rarely A and usually B, C, and D. But again, these green top guidelines are nice for some guidelines when you're dealing with a patient who has one of these conditions, and often it'll be a patient that you've never seen before with this condition. Next slide, please. Okay, so let's turn our attention to disorders of fibrinogen. These conditions include a complete absence of fibrinogen, afibrinogenemia, decreased fibrinogen, hypofibrinogenemia, and dysfibrinogenemia, which essentially is a normal fibrinogen but is not functioning correctly. And these all may present with a variety of phenotypes and inheritance patterns. They can result in bleeding and thrombosis during the intrapartum period and even postpartum. What's usually avoided is neuraxial anesthesia, nonsteroidal analgesics, and intramuscular injections. Next slide, please. Afibrinogenemia represents a complete absence of fibrinogen, as we discussed, and it has a prevalence of about 1 in 1 million. And I apologize, I did not put that up in this slide, the prevalence. It is inherited as an autosomal recessive, in an autosomal recessive fashion, and the risks in pregnancy include an increased risk of both placental abruption and postpartum hemorrhage. It is usually managed with administration of fibrinogen concentrates throughout pregnancy to reach an initial goal of 100 milligrams per deciliter and at least 150 milligrams per deciliter to reduce the risk of postpartum hemorrhage. But again, in terms of the frequency of these administration of these concentrates and when you start is a little bit unclear, but I will discuss that when we get into dysfibrinogenemia a little bit. Next slide, please. In the intrapartum period, there were reports of fibrinogen infusions given with a goal of reaching 200 milligrams per deciliter to prevent and manage bleeding. For fibrinogen levels less than 50, it is recommended to consider prophylaxis throughout pregnancy, and with administration of fibrinogen concentrates twice per week is often done. I remember as a fellow doing this at Duke where someone had a fibrinogen level that was very low, less than 50, and I remember them coming in about twice a week for administration of fibrinogen concentrates. One thing that's really important here is that there's some data to suggest that for patients who do not begin prophylaxis prior to 5 weeks gestation, antepartum bleeding was always noted. Now, this is potentially problematic because a lot of patients don't even know they're pregnant until then. And one thing that I'm not putting on a slide that's very important is I would encourage anyone with these conditions who is thinking about getting pregnant to have preconception counseling, which I think is something that is way underutilized with both a hematologist, if you have access to a hematologist, and a maternal fetal medicine physician, again, if you have access to that subspecialist. This can always serve to help optimize a pregnancy and have patients be on the lookout for when they have a positive pregnancy test. I do think that some patients with these conditions may be told that they can't get pregnant or shouldn't get pregnant. And I think that it is important to have risks and benefits discussed, which is the purpose of a preconception counseling visit. And then it's a matter of shared decision making in terms of pregnancy and how it would be managed. But I think information is power for patients who desire pregnancy, because I think that some of them can actually have some of their anxiety allayed a little bit at least, even though they know it's a high-risk pregnancy. And finally, getting back to afibrinogenemia, neuraxial anesthesia is usually avoided. I should just add here that for all the conditions that we're talking about, I think that if you have the availability to set up an antepartum anesthesia consult, that could never hurt. I realize that that may not always be possible, but especially for conditions like this, I would definitely encourage the patient meeting with anesthesia prior to delivery, usually in the early third trimester. Many of them are going to require general anesthesia if a cesarean section is required, and there's also going to be alternatives, since many of them, as we have discussed, are not candidates for regional anesthesia. Okay, next slide, please. So this is very interesting, and I was thinking about when I put together this talk, what is the role of fibrinogen and its relationship to the placenta? Because we talk about this risk of placental abruption, and why is that happening? Is fibrinogen like some sort of glue in a way that helps anchor the placenta to the uterus? And this study that I'm showing you here from 2002 was a really elegant study looking at the placental implantation site in day 6 mice embryos. So the mouse on the right, that was screen B, was actually devoid of any fibrinogen. And you can see with the circle, the yellow circle, bleeding at the implantation site in the uterus. It has been proposed that there is a need for maternal fibrinogen for proper anchoring of the cytotrophoblast after they invade the endometrium. There is other data looking at the role of fibrinogen in pregnancy in afibrinogenemic animal models and in vitro models of human trophoblast proliferation. Dysfunctional maternal fibrinogen may affect the ability of the early placenta to remodel, and insufficient fibrinogen may be unable to prevent bleeding, thus potentially influencing pregnancy outcome. All of this may explain the increased risk of placental abruption during pregnancy, and thus the importance of prophylaxis starting very early in pregnancy. Next slide, please. Now, with regards to dysfibrinogenemia, fibrinogen levels are usually normal, as we discussed, but function is impaired. And the mode of inheritance here is usually autosomal dominant rather than recessive. And the associated complications here may include both bleeding or thrombosis. There have been multiple reports of placental abruption occurring in the second and third trimester. I recall a patient when I was a fellow at Duke with this condition who had a severe placental abruption at approximately 19 weeks and developed DIC. And I remember thinking about it and talking to Dr. James about this. You probably won't remember, it was such a long time ago, but thinking about this is almost a slippery placenta. And basically the patient had bleeding, and as opposed to a lot of conditions where someone has a placental abruption, this placenta basically just kind of fell out after all that bleeding, and the patient was in DIC. And that patient actually had been receiving some fibrinogen concentrates, even though I don't remember the frequency and the dosage. One thing that's important with regards to dysfibrinogenemia is personal and family history assessment. And this is important when assessing for the need of thromboprophylaxis. Some patients with dysfibrinogenemia will have a thrombotic phenotype or other risk factors for venous thrombosis. And in these patients, one should strongly consider thromboprophylaxis with low molecular weight heparin. You can see here some of the doses from case reports of successful pregnancy, where one used 2 grams of fibrinogen 3 times weekly. And although the goal is at least the hundreds, and that's what we talk about when we think of just, we see a lot of hemorrhage, of course, during pregnancy, and we think about at least 100, but ideally you would want it to be more than that. I start getting nervous when I start seeing fibrinogen levels, greater than 150. There really isn't a fibrinogen level that correlates absolutely with placental abruption, at least as far as I'm aware. And then after the administration of 2 grams of fibrinogen 3 times weekly, often there'll be increasing doses of fibrinogen as you're targeting those goals. And you'll see one regimen in the literature of 10 to 14 grams per week. Okay, winding down here. Next slide, please. So let's finish with discussing 2 inherited platelet disorders. And I have to admit that I have personally not had the opportunity to see these patients, even though I'm hoping when our hematology clinic opens that we will get a chance to see these patients. And I would love to hear from anyone that does have some experience, even though no one's going to have that much experience. But I would love to hear anyone's experience with patients that have these conditions. So let's first talk about Glasman's thrombocythemia. So this is a rare autosomal recessive disorder caused by a quantitative deficiency of the platelet glycoprotein GP2B3A, which is the major platelet receptor of fibrinogen. Now, absence of this functional GP2B3A leads to defective platelet aggregation. And I use that term importantly to distinguish between the next condition we'll talk about, where that's a problem with platelet adhesion. And this defective platelet aggregation seen in Glasman's will lead to markedly impaired primary hemostasis. Now keep in mind that activation of the glycoprotein 2B3A is essentially the final common pathway for platelet aggregation. Complications of Glasman's include intrapartum bleeding, primary and secondary postpartum hemorrhage. Many will administer TXA at the onset of labor and continue postpartum until lochia is minimal. And again, there's a lot of inherent subjectivity here in terms of for how long you're going to do that and how often. For those with a history of bleeding, HLA-matched platelet transfusions and or recombinant factor 7 should be given prophylactically at delivery with repeated doses as warranted. Next slide, please. Now, in the chance that there is concern that the fetus is homozygous for this condition, procedures in the intrapartum period that may increase the risk of intracranial hemorrhage, such as operative delivery, i.e. forceps and vacuum-assisted delivery, or fetal scalp electrodes, or fetal blood scalp sampling, which is usually really not done much anymore. Usually those are avoided. Now, similar to maternal alloimmunization to paternally derived red blood cell antigens, which can lead to hemolytic disease of the newborn, and also similar to NATE or FNATE, fetal neonatal alloimmune thrombocytopenia. You can also have maternal alloimmunization to paternally derived fetal platelet antigens that are the GP glycoprotein 2B3A that can result in fetal thrombocytopenia and increase the risk of fetal intracranial hemorrhage and other fetal bleeding. Again, neuraxial anesthesia is typically avoided, and prophylaxis with platelet transfusions may be used prior to delivery and continued for several days postpartum. Next slide, please. Let's finish up with Bernard-Soulier syndrome. This was a syndrome that was discovered, I believe, in the 1940s. There's not really that much on this during pregnancy, even though there is a paper that does talk about this. I'm happy to send that to anyone, and that's in the list of references as well. And again, recall that this syndrome is characterized by the absence of ristocetin-induced platelet aggregation caused by quantitative or qualitative defects within the membrane glycoprotein 1B95 complex, which is a primary adhesion receptor of platelets. So again, we're talking about platelet adhesion here. This complex mediates platelet adhesion to the blood vessel walls at sites of injury. So again, there's a site of injury, collagen is exposed, and you have this complex that helps the platelets adhere to the blood vessel wall, and it helps by binding on Willebrand factor, and then ultimately enhances the capacity of thrombin at low concentrations to activate the platelets. Like Glanzmann's, Bernard-Soulier is inherited in an autosomal recessive fashion, and like I said, in contrast to Glanzmann's, which is a defect in platelet aggregation, this is a problem with platelet adhesion. There is usually thrombocytopenia, and the platelets are large. In Glanzmann's, actually, usually the platelet count is normal and the platelet size is usually the same. Is usually normal. Both antenatal and postpartum hemorrhage may occur in Bernard-Soulier, and both prophylactic transfusions and TXA may be administered. If there is a history of bleeding, prophylactic platelet transfusions can be given at the time of delivery or prior to a cesarean section. Now, similar to Glanzmann's, TXA should be administered intrapartum and continued postpartum until lochia is minimal. And neuraxial anesthesia, a common theme that we've been discussing, is typically avoided. Well, okay, thank you. That ends this portion of the talk, and I'm going to send this back to Dr. Frank for Q&A.
Thank you. That was such a great talk. Really appreciate that and learned a lot. So we're going to proceed with the Q&A part of the program right now. And as a reminder, you can submit your questions in the chat box on the right side of your screen.
Dr. Frank, you are muted.
Well, just waiting here for anyone have questions. Don't be shy. I will start asking questions if there are none. Okay, we have our first question. What type of pregnancy loss has been associated with factor 13 deficiency? Early loss, less than 10 weeks, or later loss, say fetal demise at 12 to 16 weeks?
There is really not great data on this. That's a great question. I've seen that there's some reports of early loss, more so than, say, a fetal demise in the late second trimester or even in the third trimester. Now, the problem with that a little bit is there's a reasonable risk of loss that's early for all pregnancies, right? Whether it's a chemical pregnancy or a clinically recognized pregnancy. So sometimes it's hard when you see these case reports talking about this deficiency and risk of spontaneous abortion in the first trimester, where you can truly attribute that loss to the deficiency. But I would say that most of these tend to be early losses without great data to support that. And again, even if you had a loss late in the pregnancy, often intrauterine fetal demise, stillbirth, late in pregnancy, there is often no etiology. Now, if I saw a loss that was due, say, to a placental abruption, then I think you might feel a little bit better of attributing to the cause of that demise to that specific factor deficiency. But again, tough question to answer because we're talking about just level 3 and 4 evidence with grades of recommendation that are C and D, and we don't really have much any grade A recommendations. And we're never going to have a RCT and prospective trials for these types of patients. There's not enough numbers, and I'm not sure that a pregnant person from an ethical standpoint would participate in receiving versus not receiving whatever is available, even though we don't know if it always will work. Thank you for that question.
Okay, we have another question here. What is the best anesthesia option if neuraxial anesthesia needs to be avoided?
That's a great question. And one thing, again, is if you have the ability to arrange for an antepartum anesthesia consult where this can be discussed with the patient, that is ideal. One thing that I think is great, because we have other patients here that are not candidates for many reasons. We have one recently that has arteriovenous malformations in her spine, is not a candidate for regional anesthesia. And for her during labor, a fentanyl PCA worked really well, actually, if that is something that's available to you in your labor and delivery units. You can get into other things like, doses of fentanyl periodically, or some people use, other narcotics. But sometimes that is tough as you approach, if it's a longer labor and you're approaching more of active labor in terms of adequate pain control. I trained in the eras, I'm old enough, where we did pudendal blocks, but a lot of people are not doing that, particularly when it comes to the second stage and pushing. That is another option. Another option that some people might consider is an assisted delivery, but it's different that in some patients that we do assisted deliveries on are in patients who Valsalva is contraindicated. Like we have one patient that has essentially hemangiomas in the spleen, and there's reports of catastrophic splenic rupture in those patients. So for delivery, we're planning on an assisted delivery, usually with forceps, sometimes vacuum, but usually forceps in these patients. In these cases, one could consider an assisted vaginal delivery if pain control is really hard and you just want to get the baby out. But of course, the problem there is the assisted delivery itself without adequate pain control is going to be tough. For example, putting on forceps. So a vacuum might be better. But then you run into another problem. If you're concerned about bleeding risks in the fetus, as we've talked about, you're not going to do an operative delivery. So it's tough. If you don't suspect an operative, the fetus to be homozygous, and granted, in most cases it won't be, then it might be reasonable if you need to do an assisted delivery. We didn't really talk much about that because there really is no data about if someone is a heterozygote, the fetus that is, for factor 11 deficiency, and you put on forceps, what is the risk of intracranial hemorrhage or subgaleal hemorrhage, which is a risk for all babies who have vacuums applied. Of course, that data does not exist. So it's a tough one because you get a little bit stuck in what to do. And it's a little bit different than, say, someone with von Willebrand or like a hemophilia, a patient with hemophilia A factor 8 deficiency, where the fetus is a female and you haven't done prenatal diagnosis, and there's a possibility that the fetus is a carrier. So you assume the fetus is a carrier, and you will not do any kind of invasive procedures. So that's a case when you wouldn't. But that's a different mode of inheritance, of course, and that's X-linked, so that's different. So that's the best I can do to answer that question. Great question again, thank you.
Okay, we have a lot of questions and comments rolling in. This is great. So going in order here, the next question is, what should prompt the obstetricians to investigate about a hypofibrinogenemia or dysfibrinogenemia?
Yeah, that's a really good question. When usually these patients are diagnosed ahead of time. So I'm assuming the question is that someone comes into being pregnant and has never had the diagnosis. And that's unusual. A lot of these patients would have a history of menorrhagia that is significant. And that's important in your history taking, usually at your intake visit. Once in a blue moon, and mostly this is von Willebrand disease, of course, because it's so much more common, you will capture a diagnosis of von Willebrand disease during pregnancy, which of course is hard when both factor 8 and von Willebrand antigen, when factor levels increase significantly. So it's hard to make that diagnosis during pregnancy. But I would say that if there was any concern about, like someone says, I had horrible bleeding during a surgery, and you had records to see that the fibrinogen was very low, and maybe the patient mentions, well, I went into DIC or something, and the notes say it's unclear why, and why the patient's fibrinogen was so low, but she actually never had a workup at all. So you definitely have to do some digging. So again, that's a great question. That's really tough, but most patients will have a diagnosis prior to pregnancy. I would also add that sometimes these patients ultimately are diagnosed with certain conditions when they have an abnormal PT. But again, why would you get the PT in the first place? And again, a little bit problematic because most patients will have the diagnosis ahead of time. And again, a lot will have very heavy menstrual bleeding, which is often not worked up. We have the benefit here at OHSU of a clinic that we call the Spots and Dots Clinic, where these patients are seen, and many of them, of course, have hemophilia. They're hemophilia carriers or von Willebrand disease, mostly type 1, and those patients are treated accordingly. And after they're diagnosed and their menorrhagia is under control, and then ultimately when they desire pregnancy, they can come for preconception counseling. Thank you for that question.
That's a good segue into the next question, which is how often are rare bleeding disorders diagnosed during pregnancy for the first time?
I don't have a good answer to that, except very, 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 I'll add three more veries, very, very, very infrequently. The best I can do. I think that that's incredibly rare that you're going to diagnose that during pregnancy. It's tough because, like I said, you'd have to do some digging. You just have to take a good history. And people that talk about, yes, I had extremely heavy periods and it was supposed to be worked up, but it never was, and all of that. But keep in mind, if you are going to, diagnose a bleeding disorder, the vast majority of these are not going to be the rare ones we're talking about that comprise only 3 to 5% at most of all the bleeding disorders. So for these incredibly rare bleeding disorders, it's going to be very rare that you diagnose it during pregnancy.
Okay, the next question is a lab-related question about, do you know of any recommendations on testing cord blood and reference intervals for collection of those specimens in order to assess the infant?
No, it's usually, so I'm assuming like if you're talking about if the fetus is at risk for a certain condition.
Yeah,
Usually,
are there recommendations for testing cord blood, and are there reference intervals for these specimens?
so number one, I'm not aware of those, but I certainly would be alerting the pediatricians to any of these fetuses that mom is a heterozygote for this condition, or if for some reason you knew that the baby was homozygous for this condition. And usually those babies might get worked up after delivery. And that's kind of beyond my scope a little bit, as discussions with pediatric hematology would be started, or at least there'd be a consult performed. And just watching for anything that's concerning clinically, but I'm not aware of anything in terms of reference values or cord blood. I could be wrong about that, to be honest with you. I'm just not aware of it.
So you're saying usually testing occurs after delivery if there's a concern, and if you're very concerned, you would just avoid your assisted delivery.
Definitely, yeah. I think you have to err on the side of caution there, and that's a judgment call. And I think that's a fair statement to say, and just making sure that you're alerting your pediatrician folks or whoever is involved, family practice, pediatricians, whoever is going to be involved in newborn care. Great point.
Okay, another question about neuraxial anesthesia. So can you consider it when levels are maintained at certain levels? So I think they're talking about for rare factor deficiencies, similar to recommendations, for example, in hemophilia, where you're trying to maintain factor 8 and 9 greater than 50% von Willebrand's. Are there recommendations for these other factor deficiencies?
So that is a really good question, and I think it's going to depend a little bit on your anesthesia department and their comfort level, okay? Often you will see that some anesthesia departments won't want to touch anyone that has a von Willebrand disease, but since, and you're mentioning two conditions where, assuming that, I mean, most people, when in regards to at least factor 8 levels and von Willebrand factor, we usually check one certainly late in pregnancy, 34, 36 weeks, pick whatever time you do. These levels are usually very high. So if someone is a hemophilia carrier with very high levels, which you would expect, I don't have a number, and no real significant history of any bleeding, I think that there are definitely anesthesia folks that would be comfortable with regional anesthesia. So again, it's a case-by-case individualized management kind of thing.
And then I think they're wondering about for other rare factor deficiencies, would you give a recommendation to anesthesia for what the factor level needs to be for it to be safe to perform neuraxial?
So great question number one. There's no data that I'm aware of that correlates with any of these factor deficiencies, what level you need, because really here what we're talking about is avoiding spinal hematomas and something that could be really bad, right? And there's really no data that I'm aware of that correlates any particular level with regards to any of these factor deficiencies with the risks that are part of neuraxial anesthesia. So it isn't like I could make an anesthesia provider aware of, hey, we have this patient with factor 11 deficiency who's pregnant, and your anesthesia person will go, I've never seen that before. And they're going to rely on you for guidance. And you're going to tell them, well, yes, there's data to show that if her level is above 0.4 of this certain factor level, that neuraxial anesthesia is safe. So again, even though none of us are going to have a ton of experience with this, I think that most anesthesia providers, particularly with the lack of data and lack of correlation between risks of neuraxial anesthesia and these factor levels, are not going to perform neuraxial anesthesia. So I think it's important to tell patients right off the bat that is very unlikely. I don't think I want to say 100%, but it's going to be very unlikely that these patients may be candidates. Now, for something like factor 7 deficiency, which remember we talked about is, the most common rare of the rare ones that we talked about, factor 7, a lot of times these folks don't need anything during pregnancy and do well with nothing, when they have, at certain levels, particularly when they're above 0.2 IUs per ml. But that doesn't mean that because they have a level, let's say 0.4 IUs per ml, that an anesthesia provider is going to be willing to do neuraxial anesthesia, or I'm going to feel comfortable telling an anesthesia provider that, oh, well, there's data to support that their level is way above 0.2, since less than 0.2 in the third trimester with a prior history of bleeding may be concerning. I'm not going to tell a anesthesia provider that, oh, their level is 0.4, so we should be fine for neuraxial anesthesia. And again, you'll see that most anesthesia providers are always going to err on the side of caution, because it isn't like it's a minor consequence or minor complication. So again, even with that, I think a lot of them would prefer to avoid neuraxial anesthesia. Great question.
Okay, I'm so sad we can't get to all the questions because these are really great questions and a great discussion, but we're going to have to wrap it up. So I just want to say thank you so much, Dr. Abel. That was such a great presentation, really insightful comments too at the end. We got some questions about whether the slides will be available. The webinar will be posted. Not sure if the PowerPoint slides will be made available, but we can get back to you about that. And as a reminder, you'll receive an evaluation at the end of this. So you'll get an email from Gladwell CME to obtain your certificate. And be sure to visit the Foundation's website for upcoming programs, and a reminder that early bird registration has been extended for the Foundation's meeting in, I believe it's in September. I haven't yet done my registration. I need to do that. So more information and registration for the conference can be found on the website. Thank you so much for your attendance, and we look forward to your participation in future programs.
And if I could just add that anyone should feel free to email me with questions that they weren't able to ask, or if they want any of the papers that I referred to. And I will talk with the leadership about providing a PDF of this talk, which I usually have no problem doing, but we'll work on that too and try to figure out the answer to that. And thank you again.